is with great honor to present to you our next speaker. Comes from Milan and Dieo. She's a plastic surgeon. Is Professoressa De Lorenzi. And she will be talking to us about conservative mastectomies and implant-based reconstruction. Professoressa, the floor is all yours. Thank you.
Thank you. Thank you, Chairman, colleagues, Kalimera. I want to thank EMIS for the invitation and the scientific committee. I'm very honored to be here and share with you my experience in conservative mastectomy and implant-based reconstruction. And I have no disclosure for this presentation. Over the last 50 years, there has been a revolution in cancer concept and knowledge, and we moved from the maximum tolerant treatment to the minimum effective treatment, from the extended radiosurgery to targeted conservative treatments, and from the anatomical concept of cancer spread to the biological concept of cancer spread. And Umberto Veronesi was a pioneer of conservation, and he promoted breast conservation for small breast cancer, but even conservative mastectomy, allowing to spare the skin envelope, the subcutaneous tissues, the nipple and areola complex if they are not involved by the disease, and the pectoralis major muscle and its fascia. And this is the first paper published by Professor Veronesi in 2003 with the first experience and the feasibility of his technique. And in addition, nowadays, over 30% of breast cancer are diagnosed as non-palpable lesions, thanks to the spread of screening programs, women awareness on breast cancer, and mammogram with tomosynthesis. And of course, this makes conservation of the breast, conservation of the body image more and more possible. And finally, improved knowledge in hereditary breast cancer and mutation carriers outlined a subpopulation of healthy women requiring risk reduction option. And among these options, conservative mastectomy and risk-reducing mastectomies. And these healthy women are best candidates for reconstruction after conservative mastectomy. So far, nowadays, we can carry out conservative mastectomy through aesthetical incision in the breast, the similar incision we use for cosmetic breast surgery. So in case of small to medium-sized breasts and large areola, we can carry out the mastectomy through hemiperineal incision just in the inferior border of the areola, sparing the vascular supply of the nipple and areola complex. Or we can have the so-called round block approach, which consists of a complete perineal incision and deepitalization when we want to move the nipple and areola complex, sparing its vascularization. Or mastectomy can carry out through the inframammary fold, so the incision, the scar can be hidden in the natural folds. And even in cases of large apoptotic breast, using wise pattern approach, we can achieve really outstanding results. And this is a case of a left mastectomy and a right reduction, and the implant is below the dermal flap in the inferior pole and the pectoralis major muscle in the upper pole. And moreover, thanks to the advances in reconstructive techniques and the development of new material, we can now use the prepectoral space. And for reconstructive surgeons, this is really a revolution, since using the prepectoral space, we can achieve more natural reconstruction, low morbidity, less pain, quick recovery in comparison to the conventional subpectoral reconstruction. And this is a case of a unilateral mastectomy and a medial reconstruction with an implant using the prepectoral space. So probably in the past, we could achieve this result only in using flaps. Today, this is possible thanks to the prepectoral space. So there is a trend, even in reconstructive technique, towards the conservation. And this trend is confirmed by the data in the literature. So this data are coming from the American Society of Plastic Surgeons, is the report of procedure in 2023, and more than 80% of post-mastectomy, immediate post-mastectomy reconstruction are implant-based. And in Italy, we have similar data. So we have the Seno Network Working Group collecting data from different best units. And even in Italy, the implant-based reconstruction are really popular, much more popular than autologous reconstruction. So how we can use the prepectoral space? We can use collagen matrices, we can use synthetic mesh, or we can use polyurethane foam-coated implants. The first attempt to use the prepectoral space is coming from Dr. Berna. He's an Italian surgeon. And in 2014, he published this paper, and he called his technique the muscle sparing technique. The idea was to complete wrap the implant with the matrix. So we know that matrix and biomaterial can modulate the foreign body response at the interface between the implant and the patient, so they can reduce the risk of capsular contraction in the prepectoral space. And the complete wrapping allows for an anti-contracture effect to be extended over the entire implant biological tissue interface. And what we know that is the matrix is properly implanted, there is a cell migration from the living tissue to the ADM. So the ADM can be revascularized and regenerated into patient's tissues. So I started with this technique in 2019. Of course, I have a learning curve and some technical tweaks to improve, to have the correct use of the matrix, because my goal is to ensure matrix integration, and we know that there is no integration if we don't use the matrix in the proper way. So first tweaks, when we do mastectomy, we have to limit the use of electrocautery, and instead we have to use cold blades as scalpel or scissor. And then if we want to have viable tissues and we want to revascularize the matrix, we have to avoid the use of povidone iodine solution inside the implant pocket and around the matrix, because this solution is cytotoxic and cytolytic. And then when we wrap the implant with the matrix, we have to stitch the matrix with interrupted sutures where the two flaps of the matrix are well overlapping, just to prevent any traction on the matrix and rippling of the matrix itself. And this is my first reconstruction with this matrix. You can see single stitch, but now we are using the 3D lens shape matrix. It's much more easy. The matrix is porcine matrix. It's 6 millimeter in thickness, and it is pre-carved, and it is provided as dry, and in 3 minutes in saline is rehydrated. And then in this case, the matrix and the implants are inserted in the prepectoral space using this suture to stitch the matrix and the implant to the prepectoral muscle or fascia. So when I put the matrix in the prepectoral space, I usually use 3 stitches to the pectoralis major muscle in the upper pole to prevent the rotation of the implant. And then I use several interrupted stitches between the matrix and the subcutaneous tissue to promote the integration with the matrix. And then I usually separate the axilla from the prepectoral space, so I close the connection between the axilla and the implant space if the axillary surgery is performed from the same skin incision. And I usually refresh wound margins at the end of surgery. And then another opportunity to use the prepectoral space came in 2018 by Dr. De Vita, again an Italian surgeon. The idea was to use the polyurethane foam-coated implants. And we started with this technique in 2020. At the beginning, we were really prudent. So in the first year, only 44 patients, but then the number are increasing. Last year, we used more than 300 of these implants. It's very simple to use these implants. And our early experience, implant loss is quite low, only 3.5% of implant failure and implant removal. And capsular contracture rate was really satisfactory. It was classified as 3 and 4 only in about 70% of the patients. And this is an example. So left mastectomy, in video reconstruction with polyurethane implants in the prepectoral space. And on the right, we perform an augmentation through incision in the inframammary fold. And the follow-up is at 3 years follow-up. And this is another case, so really large amptotic breast. If we're using the polyurethane implants in the prepectoral space, we can have this grip effect and also a lift effect. So in this case, the implant was really huge, 600 millimeter, and we could achieve this result only with incision in a radial incision in the external quadrant with no PESI, no incision around the nipple and the areola. And in my experience, using this implant in this large breast is a good and effective alternative to skin-reducing approach that, in my hands, have a higher percentage of complications related to difficulties in wound healing process. So matrix or not in the prepectoral space, I use both techniques. The great advantages of using matrices is that you can use the implant you want. So for those surgeons who are afraid to use polyurethane, they can use both round or anatomical implants. They can use smooth, nanotextural, and microtextural implant in the prepectoral space. So if you want to use the implant you want, you have to use the matrix. And what to do in case of unilateral post-mastectomy reconstruction when patients doesn't ask for any symmetrization of the healthy breast. In case of a small breast with a large width, low projection, I prefer the matrix because to achieve symmetry with a healthy breast, I can use more shapes are available, more size are available, so I can use implants of any company. In case of bilateral post-mastectomy reconstruction, I prefer polyurethane because I can achieve symmetry between the two breasts using two similar implants, because the perioperative time is shorter and this solution is also cost-effective in comparison with the use of the matrix. In case of lab breast, I told before, I prefer the polyurethane because in this case, using the matrix is quite difficult, surgically difficult, because the skin envelope is large, so we need multiple stitches between the matrix and the pectoralis muscle, but also to the subcutaneous tissue. And then I'm afraid of not complete matrix integration. In case of patients with a little amount of adipose tissue, so even in case of bilateral reconstruction, I prefer the matrix, because if I use the polyurethane, there is a grip effect between the implant and the subcutaneous tissue, so the wrinkles of the implant are more visible. And in skinny patients, on the other hand, with little adipose tissue, subpectoral reconstruction, to my opinion, is still the first choice, but we will see this later. And in case of radiative breast, I prefer polyurethane because in this case, in these selected patients, we have a problem correlated to ischemic complication due to radiotherapy, and I'm afraid of, in case of poor vascular tissue, not to have the good integration between the matrix and the tissue. So conservative mastectomy, prepetular reconstruction are really popular. If you look at the literature trend on PubMed, the number of papers on this topic are increasing exponentially. But I believe that is not for every patient. So I believe these cases are a good indication for prepetular space. And in case of skinny patients, they are really difficult to correct because these patients have no adipose tissue enough for grafting. So what to do in case of patients with a good vascularization, the mastectomy flaps after conservative mastectomy, but the so-called type 1 according to the Rancati classification. That means that the tissue, the adipose tissue at the upper pole is lower than 1 centimeter. The first solution is to use the prepetular space to have a natural shape reconstruction, and afterwards adding multiple sections of fat grafting, as in this case. But in case of really skinny patients with no available tissue, adipose tissue, what I do is the so-called dual plane reconstruction. We published this paper, this technique last year, and it consists of a classical submuscular, adipofascial pocket, and afterwards we are going to discontinue the adipofascial system in the upper pole to achieve more projection. These are some technical steps. So conventional submuscular adipofascial pockets, and then the adipofascial system is horizontally discontinued, and then the muscle is sutured to the inferior mastectomy flap. And this is an immediate result after surgery, just in the theater. So you can see a good projection at the inferior pole just at the end of surgery. So in this video, you see the conventional pocket behind the muscle in the upper pole, behind the fascial system in the inferior pole, and in this case, the pocket is in continuity with the fascia of the serrato anterior in the lateral part, as in this picture. And then the adipofascial system is discontinued, starting from the lateral border of the pectoralis major muscle towards the midline and stopping at least 2 centimeters for the midline, just to guarantee the anchorage of the muscle of this point. And in this case, you see the sizer is in place, and we can discontinue the adipofascial system as much as we need, just to achieve projection in the inferior pole. So which are the main effects, the advantages of the dual plane pocket? We expand the implant pocket so we can use larger implants, so we can do direct to implant reconstruction, so a one-step procedure, also for those women requiring larger volume. And then enlarging the inferior pole of the pocket, we can achieve a natural shape mimicking the top tip breast. Let's see some example. So this is a lady with a small tumor, small breast on the right side. The indication was a conservative mastectomy and an immediate reconstruction with a definitive implant and a contralateral left augmentation to the inframammary fold. This is a similar case, a young woman, really skinny one, small breast. She asked for a larger volume. So on the right breast is an augmentation, dual plane augmentation. On the left breast is a post-mastectomy dual plane reconstruction to the radial incision. So we can achieve just in one step this kind of results. And this is another case. So the second indication, this is a middle-aged woman asking for natural shape implant breast reconstruction, mastectomy on the right side, augmentation on the left side. You see is behind the muscle in the upper pole. You can see the animation deformity, but the result is really natural. And on the right breast, the mastectomy has been performed through the perireolar incision. And this is the last indication. So when I have to do a unilateral reconstruction and I need to have a ptotic breast, as in this case on the left side, I can use the dual plane. So this lady underwent left conservation and a bilateral mammoplasty, so it was an oncoplastic procedure. Unfortunately, imaging was positive, requiring for completion mastectomy on the left, and in one surgery we could achieve this result through the radial incision in the external quadrant using this dual plane technique. And then to conclude my presentation, some comment and reflection on the conservative mastectomy, implant-based reconstruction in irradiated breast, which is a kind debate issue. The question is, can we do conservation in irradiated breast, in irradiated tissues? Can we do implant-based reconstruction in irradiated breast? And the rationale is based on the synergy of different tools. So we have conservative mastectomy, sparing the subcutaneous tissue. We have the prepectoral space, and we know from the literature that the risk of contracture in case of post-mastectomy irradiation is 3 times less in comparison with the submuscular reconstruction, because in case of submuscular reconstruction, when the pectoralis major is irradiated, then it's becoming fibrotic, and then it's dislocate the implant upwards. And then we have materials against capsular contraction, so I mean matrices and polyurethane. And then we have fat grafting that we can use as a tool to improve the tissues after irradiation. And then we have also data from the literature. So I want to talk about the IBEX study, which is the largest multicenter data collection on prepectoral reconstruction with matrices, and is a multicenter study. 30 centers involved, 1,186 patients, and almost 1,450 procedures, being some of these procedures bilateral. And from the study, we know that although radiotherapy appears as a statistical relevant risk for development of capsular contraction and implant loss, we know that in cases of irradiated breast, the implant loss is 11%, seroma formation is 11%, and capsular contraction is really low, is 5%. So these data are quite encouraging. So if I had to answer this question, so we can do a conservation in irradiated breast, and my answer is only in selected cases. So a strict and accurate patient selection is needed. And this is a patient who underwent breast conservation on the left side, and then so it has been irradiated on the left side, and then she required a bilateral risk-reducing mastectomy. She wanted to maintain her volume and projection. So what I did is a reconstruction, submuscular reconstruction. Then I used the matrix as an extent of the pectoralis major to achieve this volume. And in this specific case, I could overcome the difficulties and the limitation of autologous techniques in thin patients, because in this kind of patients, bilateral reconstruction with autologous flap lack both in size and in projection. And this is another case, again, conservative treatment for left cancer, the need of a completion mastectomy for a local relapse. She didn't want to have a major surgery, no flaps, no additional scar. So we did a prepectoral reconstruction with polyurethane with a quite satisfactory result. Probably we are going now to add some fat with fat grafting to improve the upper pole of the reconstruction. So in selected cases, we can do conservation. Or on the contrary, I still believe that in irradiated tissue, autologous reconstruction are the first choice. And I thank you for your attention.
Thank you very much for your excellent presentation. Questions? What do you mean by saying conservative mastectomy? by terminology? And also, what do you mean technical point? Are you living behind breast tissue? Conservative means conservation, means no mastectomy. For my point of view, mastectomy means to remove the whole breast. What do you mean by saying conservative mastectomies?
I told before, so conservative mastectomy, you can spare the skin.
That's okay.
The subcutaneous tissue.
Yeah.
You can spare the nipple endometrial complex.
That's fine.
If it's not disease, you can spare the pectoralis major and its fascia. So it's conservative because you can conserve your body image, but you remove all the glandular tissues. It's a normal mastectomy.
When you're doing nipple-sparing mastectomy or skin-sparing mastectomy, this is a mastectomy.
Yes, it's a mastectomy.
You're leaving behind skin. You are leaving behind in the nipple areola, nipple sparing mastectomy. You are leaving the nipple behind, fine, perfect. You are leaving the muscle behind, fine, perfect. You are leaving the skin behind, fine, perfect. This is called mastectomy. Conservation means to leave behind breast tissue, from my point of view.
Yeah.
Are you leaving behind breast tissue?
No, I don't.
Okay.
I do not.
Okay.
I think it was a term used by Umberto Veronese, if I'm not mistaken. Yes. So, can I also ask a question? Because you said you close the space between the axilla and the breast. Can you tell me why do you do that? Or
Yeah, I usually close. So in my hospital, we usually use the same incision just to achieve also the axilla. I usually close this tunnel with single stitch because I want to prevent the fluid coming from the axilla going to the pocket. So I do always just to prevent seroma formation and maybe also infection. Yeah.
When you're using the ADM, what kind of percentage of seroma formation do you have, and how long do you leave the drainage?
Okay, in the literature, the data from the IGBA study, they say that seroma formation is 7%. In my hospital, it's higher. We have almost 10-11%. We usually take the drain in place when the fluid per day is less than 20-30 cc. So sometimes you have to take the drain in place for 20 days. So I believe we have a higher percentage of seroma formation because we remove earlier the drain because I'm afraid of infection.
Do you have the same seroma formation by using the polyurethane implants?
It's the opposite. When I use the polyurethane, the seroma formation is really low.
Dr. Spadakis, do you want to speak?
Conservative breast image mastectomy.
Yes.
This is the terminology by Professor Nava, I think, yes? Or
yeah, Professor Nava.
Professor Veronese.
Yeah, Veronese and Nava. Okay. Yeah, is a mastectomy. Is a nipple or areola sparing mastectomy, but what you can conserve is the shape and the body image. Yeah.
The shape. Dr. Maragoudakis.
Thank you. Are you leaving any breast remnants between the implant and the pectoralis major? Because this is of great importance from the radiotherapy point of view.
Are you leaving any?
Any breast remnants, any focuses of normal breast between the implant and the pectoralis major?
We don't leave any breast.
Okay, that's what of my interest. Thank you.
Yeah, never.
Dr. Nasasakou.
Thank you very much for this very, very nice presentation. I would like to ask you, in which cases would you go with an inframammary incision? Do you prefer this in some patients? Because from the point of the blood supply and the aesthetics, actually, it is better.
Thank you for this question. So 3 points. First, the oncological point of view. Our surgeons don't like this incision because sometimes if the breast is large, it's difficult to achieve the upper pole. So first, oncologic. So we do in small breast, small to medium-sized breast. From the vascularization, there was beautiful data from Professor Rancati, Argentina. He wrote that when you do this incision in the inframammary fold, you have to stay in the lateral part because in the medial part it is one of the main vessels for the vascularization of the nipple and the areola. So you have to do laterally, not to interrupt this vessel. I don't remember that question.
That was all actually.
Yeah.
That was all.
But there were papers by Professor Rancati.
Yeah.
He studied the anatomy, and the safer is to be really lateral.
You go a bit, if you are at the left breast, you go a bit laterally from
Yes.
6 hours up to 3
So,
hours.
the vessel is at
approximately.
6 hours, so maybe
Yeah.
7
Yeah.
lateral.
If
Yes.
you have a large breast, of course, it is difficult. But
It's
if you
really
have a
difficult.
small to medium breast,
Yes,
it's,
I agree.
I think it is
Totally
a good
agree.
incision.
In fact, you saw in my presentation, in really large breasts, I prefer the radial incision because you can achieve all the quadrants of the breast. So our first items is oncological safety. So it's a compromise, and the aesthetic incision I show just in selected cases. The majority of that cases were healthy women requiring for a risk reduction mastectomy. But even in those cases, we have to remove all the breast. So yeah, we cannot do in all patients.
Thank you. Thank you very much.
Thank you.
Professoressa, can I also ask something else? When you have less than 1 centimeter of tissue, because of the Rancati and Nava mapping, do you go for 1 stage or 2-stage reconstruction, or you use dual plane as a 1 stage? And secondly, do you have any indications in EO when the patient will receive radiation therapy on what kind of reconstruction you'll be doing, or it depends on the surgeon, the plastic, or and your experience? I think radiation therapists know more about that. What's your experience with proton? I know that you have proton being one of the few hospitals in Europe, which is something amazing, something that maybe will change our everyday practice. What's your experience on that?
Okay, 3 questions.
Yeah.
The first one is what to do when Rancati type 1 centimeter less. Yeah, less than 1 centimeter. First, you have to talk with the patient. So if the patients have fat enough to do fat grafting, I can discuss with the patient and say, okay, we can do prepectorally. It's really more comfortable because when you move, you don't any to complain. But you have to agree to do one surgery and probably 1 or 2 grafting. So we do in under local with the mild sedation, we do day surgery, but in any case, the patient should come again. So you can discuss. If the patient doesn't have fat enough, I do subpectoral, no other solution.
1 or 2 stages?
No, subpectoral 1 stage. So all the cases I show are 1 stage. Dual plane. Second question was about radiation.
Yes, if you have any indications in EO.
We have indications. So for us, autologous reconstruction is always the first choice, but autologous reconstruction is also fat grafting. So we decide case by case because when we do the first consultation, we look for risky factors. So irradiation is one of these, but also the scar in the breast. If the patient is a heavy smoker, if she has comorbidity, if she has, if she's doing chronic therapy. So, and also the shape, the volume of the breast, the thickness of the skin. So it's is an algorithm. So it's multiple choices. And in those patients with not favorable issues, we do for autologous. Otherwise, we can do conservations, but just in selected cases. And last, in a year, we do proton therapy just for re-irradiation in the breast. So our radiologists use proton for other disease, neurological, especially tumor, the nervous system. And in the breast, we do only in case of re-irradiation, because it is more targeted. But we don't do daily, of course.
When you have a really thin flap, do you use ICG at all or no?
Not anymore. We did in the past, but if the flaps are really thin, we go for autologous.
Okay.
Yeah.
That's very kind.
We don't do routinely. Okay.
Okay. Thank you very much for your talk. Very
Thank
good.
you. Thank you very
Thanks a lot,
much.
Professor.